Hello everyone, my name is Natalie Tapaskar and I am currently a third-year internal medicine resident at the University of Chicago in Chicago, Illinois. Today I'm going to be speaking about an article that will be published in Gastrointestinal Endoscopy. The title of the article is Comparison of Clinical Prediction Tools and Identification of Risk Factors for Adverse Outcomes in Acute Lower GI Bleeding. This was a prospective observational study of 170 patients that were admitted to the University of Chicago for lower GI bleeding and underwent colonoscopy. This study occurred between 2016 and 2017. The premise of this study was to further our understanding of the risk prediction tools that exist for stratifying patients that are admitted with lower GI bleeds. We know that acute lower GI bleeding is a common and potentially life-threatening condition that accounts for 20% of all cases of GI bleeding. Lower GI bleeds represent approximately 36 out of 100,000 hospitalizations every year and has an estimated mortality between 5 and 15%. It's associated with high resource utilization, given that patients often experience recurrent bleeding, require blood transfusions, and often receive urgent endoscopic, radiologic, and even surgical interventions. But despite this information, there's actually limited data on accurately predicting the risk of adverse outcomes for these hospitalized patients who come in with lower GI bleeding, especially when you compare this to the upper GI bleeding population, where several validated and frequently used scoring systems exist. The difficulty that lies with standardizing a single risk prediction tool is in understanding the various clinical variables that might be important in predicting outcomes. For example, what do we consider to be the most salient pieces of information when we evaluate a patient who presents to the ER for lower GI bleeding? Do we consider their systolic blood pressure, their heart rate, their admission hemoglobin? What about their clinical presentation? Does a syncopal episode mean that they're going to require more urgent intervention than someone who presents without syncope? What about patients who have positive rectal exams for blood? Is that person more likely to require more blood transfusions or more urgent procedures? Are they more likely to continue to have bleeding in the hospital? And finally, what about mortality? Which combination of these variables best predicts 30-day mortality after a GI bleed? The purpose of this study was to compare tools that have been created by various investigators in order to analyze important clinical outcomes. Specifically, we studied 5 outcomes: severe bleeding, in-hospital rebleeding, the need for endoscopic intervention, the need for blood transfusion, and intensive care stay. We evaluated 7 tools that have been created by other investigators in our specific population of 170 patients. Our study is unique in that we included both upper and lower GI bleeding risk tools. We also served to identify independent variables that were most strongly associated with severe bleeding. We found that those were admission hemoglobin and admission albumin. Our results also found that there were 2 scores that stood out. The Oakland and Straits scores were standouts for predicting severe bleeding and endoscopic intervention. But overall, none of the scores performed best across all 5 outcomes. This suggests that there's a more need for more simple and more powerful risk tools. Unfortunately, our study has some limitations, including its small sample size, its single-center design, and its inability to capture patients who were admitted and discharged from the emergency department. And finally, we had limited power to evaluate 30-day mortality. This study is part of a cohort of literature that attempts to standardize our approach to a common and highly resource-draining medical condition in the field of GI. Our study highlights our current shortcomings in accurate risk prediction in lower GI bleeding, and it generates a set of new, interesting questions surrounding the future role of highly intelligent and data-driven machine learning algorithms that might simplify a current, very complicated, and highly variable methodology for risk stratifying patients. The applications of this knowledge are extremely broad. For example, how can timely and efficient risk stratification improve length of stay, reduce cost, and efficiently triage resources to provide the best care? Ultimately, our goal is to strengthen the foundation of knowledge that will eventually aid in creating a standardized clinical practice tool that's highly powerful and data-driven. Thank you all for your time, and I hope you enjoy reading the article.